Welcome back. It's Siv again for Anesthesia101online.com. I know it's been a while. I haven't made a video in a while. If you listen to this on my podcast, my Anchor FM podcast is the same, Anesthesia101online.com. I'll probably post this, the audio part of this piece onto the Anchor platform, the podcast platform. If you're in the Anchor listening to this, you come on back to the YouTube channel, same thing, Anesthesia101online.com. And you can check me out. Again, I'm Siv. Welcome. Today we're going to talk about SAM, which is Systolic Anterior Motion. So basically what it is a left ventricular outflow tract obstruction. The big umbrella is it's a hypertrophic cardiomyopathy, really what it is. So I encountered this. I hope nobody has ever had to encounter this during the anesthesia. Usually, giving somebody anesthesia, it's not a fun experience. So I'm going to go ahead and share my screen with that. And share yeah, good. So with the outflow track, and I'll play this video later, and you guys can find this YouTube video. I'll give you the link to prescription for this video. So what it is the systolic anterior motion causes obstruction of the left ventricle, which normally will perfuse the rest of your three main parts of your organ: your brain, your heart, your lungs. So you need all that. So let's go through it. Hypertrophic cardiomyopathy. It could be hereditary. It could be a number of factor problems. But either way, you end up with this enlarged muscle of the heart, either between the septum, the anterior walls of the heart. And with this whole thing sticking out to the left side, which is right where you get most of your cardiac output, you have this obstruction as the heart goes in systolic. Yeah, I talk kind of funny. I got a little canker sore in my mouth. That's kind of why I'm talking that way. But anyhow, so this left obstruction, as you know, is a systolic cycle. So in the systolic cycle, it actually gets worse. So just think about it. 25% of these patients have it. They don't know they have it. They usually complain of either some kind of fatigue, syncopal episode, maybe some angina. You don't know because they never had anesthesia, they've never been under stress, so we don't have those symptoms. So basically, one of the YouTube videos describes it as a Ventricular effect. Just a little review what a Ventricular effect. So basically, it's turbulent flow, and because it's flowing so fast. Just think of you ever watch a creek? Body of water that flow down a creek. If you look at the sides of the creeks where all the leaves and the water grass reside, you'll see turbulence, flow right by it. So basically, it drags it along with it. Basically, what that it looks like. So usually, it's there's a couple of different variations to this cardiomyopathy. There is the subaortic stenosis, hypertrophic subaortic stenosis, asymmetric septal hypertrophic obstructive cardiomyopathy, and muscular subaortic stenosis. So the book I'm using is Morgan McHale. It's an older version of what I use in nursing school, so you may look that up. I think it's the new one's called Butterfield and McHale, I think. I have the old one, which is the Morgan McHale version. So if you think about this physiologically, what's happening is when blood is flowing in from the atrium and left atrium coming into the left ventricle, it's filling up with blood, but now it has to go systolic. It has to shoot out into the aortic valves right here, and it goes out to the rest of the body. Well, what happens is this back pressure will make this outflow tract close up between the mitral valve and the actual going out to the aortic valves. And I'll play this video in a few minutes. So what do you think will happen with these patients when you induce them on anesthesia? Usually, any kind of anesthetic you're inducing them without even knowing it, you give a propofol induction dose. Basically, you vasodilate the system. Now you got no blood flow count, you have no afterload, but because most patients are either NPO have had fluid restrictions, then usually their preload is actually low too. So all those two things I just described, it's actually making your SAM diagnosis worse. And with the anesthesia induction, it's going to make it 10 times worse. So what would happen is you put somebody on sleep, you induce them, put them to sleep. Now you have this vasodilation going on. Now you have no outflow. So what you'll see, cardiac-wise, you see your heart rate drop. No, you will see your heart rate go up because normally the heart rate will compensate because this outflow is not coming out. There's not enough blood flowing back out. So you see a tachycardia, but you also see hypotension. So much so, your patient will arrest. What will happen is patient arrest, you won't have no cardiac output. You'll have to start CPR, and they'll either have a pulseless electrical activity or they'll have some kind of agonal rhythm. You still would have to do CPR because the American Heart Association now advocates just chest compressions. They don't really care about the ventilated part. But thankfully for us, when this happened, the patient was already intubated, so the ventilation part was taken care of. But the chest compressions push hard, push fast. So you start to sweat because cardiac output is, I don't know, you have to get up to 100 beats per minute, I want to say, in these situations. So how would you help these patients on these anesthetic considerations? If you had an echo, if you had a CVP and an arterial line, it helps. But if the patient didn't know they had it, it doesn't help. But we were able to figure it out using TE, transit aortic echocardiogram. So we were able to see that the patient was dry. We gave him extra fluids. So now you open up your preload. You're able to give some volume back into your preload, able to squeeze through the left ventricle into your left atrium, left ventricle. Now you got some preload going on. But now, what kind of agents would you give? Obviously, my anesthetic gas was probably super low by now because at this point we had some troubles, some issues. So I mentioned earlier we had tachycardia. So the great drug that you would use in an instance just to correct your blood pressure is phenylephrine. We use that a lot. Other people call it neosynephrine, but basically it's an alpha-adrenergic agonist. So basically you're going to increase your SVR, systolic vascular resistance, therefore giving you a better high blood pressure. But that's just a temporary problem. But that's going to at least buy you some time. That'll increase your vascular resistance by doing that. But let's take care of the tachycardia. So we did try Esmol. It worked briefly. As you know, Esmol is a Hoffman elimination. It's just using plasma esterase just to eliminate the drug, so it doesn't last long. So we end up actually giving low pressure. As scary it is, as low as the blood pressure was, but if you think about it, physiologically, if you slow down the heart rate because it's going so fast, it's causing the obstruction to go into the left ventricle here. So if you slow down the heart rate, it gives more time to fill, more time to actually eject out of the left ventricle. And that's what we did. It worked well because by that time they were pretty much full from the preload that we, bolused. We were able to actually give them some kind of cardiac output, and that actually helped. Thankfully, everything went well. We had a great team that responded immediately to this situation, and we did okay. So let's play this video right now. So this is a great video. I'll actually put the link in the description there.
A narrowed outflow tract means more pressure and heart work are needed to push blood out of your left ventricle to your body. This pressure difference is called gradient. Symptoms of hypertrophic cardiomyopathy, with or without obstruction, typically include tiredness and shortness of breath, chest pain, lightheadedness, heart pounding, or fainting. Lightheadedness typically include called gradient.
So you can see there's
symptoms of hypertrophic.
Those that on the podcast won't be able to see that, but if you can go to that YouTube channel, and I'll probably put the description in my Anchor FM site also. So it's very important. It's obstruction of the left ventricle. Basically, it's either the mitral valves are not closing properly, and you got either some kind of hypertrophic septum moving into your ventricle area. It's giving you the outflow tract, and that's what you have. Okay, that's it. Very short, simple video. If you haven't already, like, comment, and make sure you subscribe to my channel. I know sometimes not as consistent, but I'll try to be as consistent as possible. Hit that notification bell every time I upload a video. That way you're notified of the new videos. And also, people have been reaching out as far as trying to apply for anesthesia school, nurse anesthesia school, and had different other various questions as far as going through their nursing program, email me. I'm going to put my personal website on there. Just email me at that website, and I actually answer all emails personally. So I try to be as thorough as possible. I may not answer as promptly because of my actual doctorate program that I'm committed to, but make sure you email me and I'll be sure to answer them. Okay. All right. I'll see you next time.